S- Slide and desktop.
Slide and desktop. Okay. Now?
Slide presentation mode.
Okay. Okay. So today's lecture, skull and brain. I'm going to skip. Usually, previous years I gave introduction regarding the normal anatomy, the normal projections, and everything. But for today's session, I'll skip that one. I think that one you should read on the basic of imaging skull and brain, all the normal anatomy and everything. So when you look at the imaging at the area of skull and brain, we use few modalities. So first I'm going to talk about plain radiograph. Okay, so when we do a skull radiograph, we can see actually many structures. Okay, so what's important for you is to recognize the sutures, how normal vessels looks like on skull radiograph, because this one usually will be mistaken for fractures if you are not experienced enough. And then normal thinning or loosened areas in the skull. Okay, of course, for fracture is one of the indication to do skull radiograph. So you have to know how fracture looks like on skull radiograph, and of course how to describe the fractures. Okay, the difference description between fracture and sutures. Okay, so if we look at loosened lines on the skull radiograph, you really have to look at the loosened linear lines to differentiate whether this is a real fracture or is actually a normal appearance of suture or vessels. Okay. But for skull radiograph, there are limitations because of the overlapping structures. So it makes interpretation difficult. You may miss fractures on radiograph, or sutures you diagnose as fractures. Okay, so we have seen this many occasions. For example, many years ago, when you complete your study, housemanship, usually you are not allowed to do emergency posting for first posting during housemanship. But few years back, they allowed housemen to do emergency posting for your first posting, and we start to receive many requests, especially when pediatric patients, history of fall, request for CT brain to rule out, to delineate the fractures, because many times the housemen, they are not very familiar. When they look at the skull radiograph, they always diagnose all the sutures to be fractures. Okay, and another thing about skull radiograph is actually it doesn't help in assessing intracranial complications or severity of the head injuries. For example, you can have a patient with a huge intracranial hemorrhage but no skull fracture, in which patients require surgical intervention. In another hand, you have a patient with skull fracture but no intracranial hemorrhage, in which conservative management can be allowed. Okay, so I'm going to give you a rough guideline how to interpret the plain film. So this is just a guideline. Okay, so you can use such same as when we teach you about chest radiograph. That's just a guideline how to interpret. Okay, so you can develop your own techniques. Okay, so that means number 1, number 3, number 2, 3, 4. It is not necessarily that you follow this sequence, so you can have your own technique. But whatever it is, you should stick to your techniques so that you are not going to miss anything when you interpret the skull radiograph. Okay, so number one, of course, important, you have to identify the examination, name of patient, site, dates, and of course quality of the image. Okay, so number two, you have to look at the normal anatomical landmarks. So, normal anatomical landmarks means when you read again your normal anatomy, same structures is always labeled. Okay, so you should be comfortable to see all this anatomy, normal anatomy, and if this normal anatomy is not seen, whether this is significant abnormality or not. Okay, and don't forget the sella region, the pituitary fossa, because even though it's a small region, this area can have many disease process that you should not miss. And then look for the overall bone of the skull region, whether there is lytic changes, so which we can see in many conditions such as metastasis of myeloma. And look for bone sclerosis also. Bone sclerosis also can occur in many conditions. We'll see some of the images later. And look for any calcification. Some of the calcification may be physiological, some may be pathological. And then of course to look at the skull fractures. Okay, so whenever you are given image like this, you should be able to identify the examination. So it's not enough that you tell me that this is a skull radiograph. Okay, so you should tell me what projection is this. Okay, so for example, this one. Okay, so this is of course a skull radiograph, frontal projection, but specifically this is Townes view. This is of course the lateral projection. So as I said, you have to know the anatomy. So try to identify the anatomical landmarks that you are familiar with. Okay, for example, all the sutures, try to delineate all the sutures, and then all the outlines of, for example, the orbital cavity, the nasal bones, okay, and then the mandible and the maxilla. So if you have, for example, in frontal projection, you have two sides. It is better you can always compare right side and left side so that you can get the abnormality. Okay, so for example, when you saw this one, this is OM view or Waters view. Okay, so usually if you do not have any approach, okay, any techniques how to look at the image, you'll be searching for the abnormalities here and there. Okay, but if you know the indication, for example, this view is specifically done to look at the facial bones and the paranasal sinuses. So you must concentrate on findings related to the facial bones and the paranasal sinuses. So many authors have proposed different ways of approaching this type of radiograph, but one of the well-known ways is you use all these three lines. Okay, so name of the lines is not important. The importance is you see, okay, first line you follow from the fronto zygomatical sutures. So there is a suture here between the zygomatic bones and the frontal bones. Okay, so this is normal suture. So if you see a gap here between the two bones, it is not abnormal. Okay, so then you start to follow the outline of the orbit. Okay, so you see there is no step, it's continuous. Okay, and then you start to see the frontal sinus. Okay, frontal sinus, both sides, you see the lucency is almost the same, no fluid level. So generally this is also normal. And you follow the orbital, superior orbital rim on the other side and going to the fronto-zygomatical sutures the other side. Okay, next you'll follow the zygomatic arch. Okay, so the zygomatic arch, so this one, some authors put this as head of the elephant and this is the trunk. So this part should be continuous. So once you see discontinuity, this is fracture, okay, and then you go to the inferior orbital rim. So the frontal bone trauma is very, very important to diagnose, okay. So you see a step here. So a step here. So there is fracture also of the inferior orbital rim, and you see the maxillary sinus on the right side is more opaque if you compare to the other side, okay. And then go to the inferior orbital rim on the other side, where you can see very smooth lines, continuous, and also now the head of the elephant, the other side, the zygomatic arch is also smooth, and the trunk you can see is very smooth compared to the other one, okay. Now you see the mandibles, okay. So mandible, important for you to see two of the processes here, okay. So it's condylate and coronate process, whether any fracture or not, and then again look at the maxillary sinus and look at the nasal region, the nasal septum, and also the lucency within the nasal region, and then the other side of the maxillary sinus, and again the condylar and coronate process on the other side. And some books put fourth line here along the lower parts of the mandible to look for body of the mandible fracture. Okay, so that's when you have approach, okay. So the other one, as I mentioned before, you always compare one side to the other side. This one is actually a skull radiograph PA view. I just cut and focus at the orbital region to show you that this one, you can see one part of the bones shadow here where you cannot see on the other side. Okay, so the finding is very, very subtle. If we do not compare, sometimes we can miss. Okay, but this one, why? Because there is actually already lytic lesion involving the sphenoid bone here because of a very big tumor. Okay, so that's how you compare the two sides. Okay, next we go to the sella region. So again, sella, as I said, is a very small area here, but you have to assess carefully. Okay, so for this one, you can see the sella is expansion. You don't see the normal saddle shape of the sella. Okay, and then you see the sphenoid sinus is also like compressed by the expansion of the sella. Okay, and then for the overall of the bones, any change in the overall bones. For example, you sometimes can see multiple lytic lesions, so you have to describe where is the lytic lesion, which bone it involves, what size of the lytic lesion, whether it's all similar size, different size, and whether there is any septation within any sclerotic margin, so whether any soft tissue, mass or lesion seen. In this case, it's multiple myeloma. Okay, sometimes you can have a solitary lesion, for example, in eosinophilic granulomas. Another lesions, metastasis can also be multiple. Okay, sometimes the changes of the bone is sclerotic, so that means whiter than normal. Okay, so you look at all these are rounded opacities or the sclerotic region. This one is a very ill-defined, okay, sclerosis of the almost all the skull is involved. Okay, so again, different pathology can cause all these sclerotic changes of the skull bone. Okay, so another condition, hyperostosis frontalis interna, is actually not really pathology. It's, sometimes it's considered as a normal variance where there is thickening at the frontal bone. But if the thickened part of the bone is very extensive, it can actually compress the underlying brain parenchyma. Okay. Next, calcification. Sometimes you can see calcification, but this one is not easy on plain radiograph. I think calcification is better visualized on CT scan. But for this one, patient has a false calcification. So you see the shape and the location is actually the normal place where the fault is. Okay, sometimes tuberous sclerosis, we can have a periventricular calcification, very faint here. So this is also old image, so not clearly seen. Tumor mass, sometimes you can see surrounding the tumor, some calcification of wall or inside the tumor itself. So you can see, so you have to describe what the calcification that you see. Sturge-Weber disease can give to gyriform calcification because the calcification is all along the gyri of the brain parenchyma. Congenital toxoplasmosis can give you calcification disseminated in the brain parenchyma. Okay, so again, skull fractures is important. So you see here, there are so many lines. There are so many loosened lines. So which one is fracture? Which one is suture? Which one is blood vessel? So you really have to determine. So if you look at the fracture, usually fracture will be more loosened than the sutures or the vessel impression because fracture involve both outer and inner table, whereas sutures or vascular impression usually will be involving only the usually for the blood vessel is either inner table or outer table. Sutures can sutures involve both also inner and outer table, but you see the location should be always at the region that you think where is the sagittal coronal sutures, and then sometimes you can see the zigzag appearance of the sutures, not linear like that. Okay, so now I think let's see what you have understand so far. So I'm going to show you a few images. You all tell me what is the findings, okay?
Fracture.
Name the examination for, so you consider this as exam films. So you name me the examination, you describe your findings, you give your diagnosis, and if any later on, then you can give the differential diagnosis, okay?
Okay.
I cannot hear you. Anybody's answering?
This was if we wanted to first we need to tell what type of investigation, isn't it?
Yes.
So is it like say this is a plain radiograph of
yes, please.
Plain radiograph of pediatric patient?
Okay.
And there's a lateral view. It's a lateral view of the skull, and there's a linear line at the. Is that a statue or a fracture? There's a fracture at the what? The superior parietal at the parietal region, continuing from the parietal and it extends until near towards the occipital.
Okay, carry on.
Ibrahim, you want to add on? Hyperdense at the base frontal region of the skull.
Okay. Anybody else want to say something about this image? Senyap je, ada kat sana lagi ke tak semua?
Ada.
Okay, so you look at this one, the example, okay? So you see sometimes even in exam, it's normal that semua orang dah tahu case ni or gambar ni fracture, okay? But why some student pass the exam, some student fail? So when we talk about exams, it's not only about your knowledge, it's also about your technique, okay? And of course, there is a bit of luck also, okay? So if we give this film for your exam, usually we ask you about name of the examination, maybe 1 or 2 marks, okay? So that's why I said always try to get full marks at this part of the question, because subsequent question describe the findings. So far I think nobody ever get full marks, okay? Because so you see here, if we give you if the marks allocated is 5 or 6 based on what was described just now, I don't think you will pass, okay, the film. So so you will start asking, how come a film like this for findings can still have 5 or 6 marks, okay? Because I think it is similar with when you do your clinical examination, your short case or your long case. When you describe something, you already have in mind what's the diagnosis, but you want also to exclude the differential diagnosis. Okay, so you know this is fracture, but you have to convince me from your description that this is fracture. So how to convince? And then from your description also, you have to already tell me this is not sutures or this is not a vascular impression, okay? Because that are the most common thing that you have to differentiate. So you see a loosened line here, okay? So yes, most, because this is only one view, so cannot really locate where, but most probably this is parietal region. So you can see a linear loosened line, which is a very sharp, okay? You see it's quite sharp, okay? And then it's branching, okay? One's going toward the occipital, one's going toward the temporal, okay? But the angle of the branch is quite acute. Okay, why it is important for you to tell? Because you have to differentiate between the vessel impression. Vessel impression, you can have branching, but usually it's like tapering and very smooth, okay? And then the lucency is like bigger at the parietal region and smaller here, which is another thing to differentiate with your vessel, because usually if you see meningeal vessel impression, you'll see bigger here and then going towards here be smaller. And then this is not located at the normal suture, because you see parts of the suture you can see here, okay? This is not at the normal suture. It doesn't have the zigzag appearance of a suture, okay? So that's how you describe. And whenever it's a fracture, so most probably it's trauma, so you have to mention about any radio opaque foreign body that you can see, and then you see surrounding whether any soft tissue swelling or the scalp hematoma or not. Okay, so this sclerotic part usually is normal because of the mastoid region and on the overlapping bones at the base of the skull. This is a bit asymmetry in positioning. If not, you look at the paranasal sinuses, whether there's any fluid levels or not. Okay, to indicate fractures involving the paranasal wall or something like that. So that's how you answer. So that's how you get all the 5, 6, 7 marks allocated. So it shouldn't be only 1 or 2 sentences. Okay. Next, can somebody answer this one? Come. If you are slow, we may not be able to finish the lecture because I'm going to stop at 10:15 to give you time for your next class. Yes. So diagnosis?
Jadi multiple myeloma.
Okay. So what you want to add? What you want to add from your friend's description?
Instead of sclerotic, I think it's more to lytic. If multiple myeloma, so there is multiple discrete lytic lesion throughout the skull, and maybe I can add. I think the size is quite. The size of the lesion is quite uniform. Okay. Then my definition will be multiple myeloma at this point. And
your diagnosis is multiple myeloma. So your differential?
Differentials, maybe I think metastasis of metastasis, and then maybe osteoporosis. Better.
Okay. So you all have done medical posting, right? Year 4?
Yes.
Okay. So basically this is quite a common image, so that I expect you all have seen before in your clinical posting, medical or surgery or I don't know. Okay, so for now, usually when you are having your radiology posting, I expect you already have some degree of knowledge or exposure towards some of the imaging. So now it's just to brush up how to describe the findings better. Okay, so if but sometimes I think with all the I'm not sure whether the COVID things or so it seems that you all are macam lacking sikit lah in term of exposure or lacking, tengok image ke apa semua-semua. Okay, so yes, there are multiple liquid lesions. Okay, you can see it's almost uniform in size. So this one is very famous exam question dalam buku. Kalau buku radiologi tak ada image something like this tu macam pelik lah. So if you read radiology books mesti akan came across with this kind of image. Okay, so multiple liquid lesions. Okay, so each of the lesions macam not really having sclerotic borders, kat dalam pun tak ada internal opacity or septation or apa-apa semualah. And then if you look, it is almost uniformly distributed, involving all the bones, maybe a bit sparing the temporal. But what's more, you can also see multiple lesions also involving the mandible. Can you see? And the visualized cervical spine also have all these lesions. Okay. Otherwise, I think scalp ni tak ada nampak soft tissue swelling. There is no periosteal reaction. Paranasal punya region pun nampak okay. Okay, so this is quite common, multiple liquid lesions in our setting. Biasanya kalau you tengok case ni in medical, always the issue of nak differentiate whether this is multiple myeloma or METS. Multiple myeloma or METS. Okay, so once you see involvement of the mandible, so this one is a bit rare for METS lah. Okay, usually multiple myeloma is more common. So METS, jarang METS kat mandible. Okay, so that's one of the way how to differentiate. So that's why that's how you have to describe, you know, in exam. So exam tak boleh satu sentence, dua sentence, because there is no way we can give you more than 3 or 4 marks with the 2 sentence punya wordings kan. Okay, so you try to get more marks. If the findings is very minimal, then the relevant negative is also can carry higher mark. Okay, so try to practice when you look at the image in the book. Try to practice how to describe the image and then look at the description given. Okay. Okay, so causes of multiple skull lesions, so can be METS, multiple myeloma, the two most common, but there are other things such as EG, Langerhans cell histiocytosis, hemangioma, osteomyelitis also, but of course all these we can only differentiate if a proper clinical history given. So that means always correlate with the clinical correlation. Okay, so this one I think to save time, I'll just straight away tell you there is actually this one is the sclerotic changes. So you can see a soft opacity almost occupies all the bones. Okay, so you can see all these sclerotic changes. So sclerotic skull lesions can occur in Paget's disease. METS also, certain type of METS, especially osteocyte and prostate cancer, is known to have sclerotic metastasis instead of lytic. Fibrous dysplasia, rickets, not well seen now. Okay, renal osteodystrophy, sclerosing bone dysplasia. This one I gave before, hyperostosis frontalis interna, prolonged phenytoin treatment also. That's why getting your clinical history is very important. And certain type of tumors can have a sclerotic changes. Okay. Yes.
Kes 3 tadi yang kat gigi tu normal ke? Yang kat gigi tu.
This one is dental filling.
Filling. Oh, filling.
Okay, next. Yang ni tadi dah ajar teknik ni. So
this is a radiograph of the skull in Waters view, and at the frontozygomatic junction there's a gap on the right side, but on the left is no gap. And there is a fluid level. I'm not sure. Okay. So this
you must complete until giving me the diagnosis.
So the diagnosis would be frontal bone fracture.
Anybody else want to give your interpretation?
Okay, I would like to try, Doctor.
Okay.
Okay, this is the occipito mental radiograph of the skull. And then there is, if you can see, the nasal bridge is not in the middle. And then there is opacity at the left side of the left side of the, and there is so diagnosis is that sinusitis.
Okay, anybody else want to give your opinion? What does the look asymmetry? Sorry? Okay. Okay. So what do you think might happen?
Doctor, can we say it as a subcutaneous swelling?
Possible. So why the patient can have subcutaneous swelling?
Because of the trauma fracture.
Can you see any fracture there?
Yes, the gap.
Okay, so if you look at the image, so I told you between the frontal bone and the zygomatic bone there is a suture there. Okay, so a suture memang gap pun, suture. So sometimes the positioning, so this side here also you can see actually, tapi dia dah overlap dengan part of this shadow, the bone shadow, but there is a gap. So fracture and suture, the way you differentiate, another thing is number one, the normal locations. So when you see this is a normal location of a suture, so you should think back before you want to diagnose a fracture. Of course, there is ada jenis fracture yang dissociation or dia renggang tu, okay. But then a fracture usually will have a sharp margin, whereas a suture dia akan ada corticated margin. So you see a very nice opacity at the border of the gap there. So that means this is not a fracture lah usually. Same as your sutures. So bila you tengok zigzag ni, you tengok actually at the border of the zigzag tu dia a bit sclerotic. So kalau fracture, because it's acute, you akan nampak, you will not see that the sclerotic margin. So we call it sclerotic margin, okay. So for this patient, so kalau you guna balik approach tu, so you see this is a suture. So whether there is abnormal widening of the suture, still you cannot rule out. So maybe you can put as possibility. But another thing is of course positioning. And then you see the superior orbital margin is normal, inferior orbital margin is normal, and then you see the suture on the other side. So when you see the zygoma, okay, so normal. So when you see the inferior orbital rim also doesn't seems to be anything abnormal. So same thing, zygoma on the other side. Okay, so when you see the condylar and coronoid process here also okay, but you start to see this maxillary sinus. When you compare to the other side, this one is the wall of the maxillary sinus. This one, the lateral wall, you see there is a step. So there is a fracture here. Okay, so there are the fracture lateral wall, and then you see the fluid levels inside the right maxillary sinus. On the left side, you tak nampak the fluid levels, but there is soft tissue opacity because this patient also had a polyp. Okay, so maxillary polyp. You can see the rounded opacity occupying the left maxillary sinus. Of course, you can see a bit of deviation of the nasal septum, but no obvious fracture or discontinuity. So this one can be a variant. Memang ramai orang yang ada variant. Nasal septum dia a bit deviated to one side. Okay, so otherwise mandible semua ni. And then what your friend notice ada a bit of opacity, yes, there is opacity here. So betul, subcutaneous or soft tissue swelling because of the fracture here. So that's why whenever you see some findings, you have to dig and dig and dig. So just like that. So macam tadi, you already saw something is not normal, you should explore more at the region of abnormality. So train your eyes and your brain that way. So you already see abnormality, jangan berhenti kat situ saja. You have to dig more and more. What is abnormal? What is abnormal? Okay. So if you see asymmetry or opacification of sinus, think about normal asymmetrical aeration. Think about infection, sinusitis. Think about sinonasal polyposis or polyps. Think about other type of neoplasm, mucocele, dentigenesis or amyloblastoma. Okay. So next we are going to go to CT scan, okay? Again, we look at the CT scan, we identify the examination, windowing and anatomical plane. We see if there is any abnormality, and if there is abnormality, whether the abnormality is hyperdense or hypodense, okay? So hyperdense can be caused by calcified lesion or acute hemorrhage. Hypodensity can be caused by edema, neoplasm or infarction. Okay, so if there is any lesion, see the mass effect of that lesion causing to the brain parenchyma. And then look for any enlargement of the ventricles. So hydrocephalus, and then if there is hydrocephalus, you have to determine whether there is communicating or non-communicating hydrocephalus. Sometimes for non-communicating, for the communicating, sometimes you have to differentiate hydrocephalus with cerebral atrophy. And then if the examination is given with contrast, see post-contrast, whether the lesion is enhanced, whether how is the pattern of enhancement, whether any abnormal enhancement of the meninges or the dura. And of course, bony changes you have to look also. Okay, so when you are given any image, for example, you are given only this one. So the proper way, if you ask to name the examination, is CT scan of the brain. This is axial plane and bone window. Okay, so you have to name. So usually if in exam we allocate 2 marks if you don't mention, you just mention CT scan of the brain. So you don't mention what plane, what windowing. So usually we'll minus half, so that means -1. Okay, so that's it. That's why I said all of you goes in the exam hall. Everybody knows this is a CT scan brain, but somebody get full marks for this, but the others can even fail when naming the examination itself. Okay, so this is the easiest part of the exam, so don't miss your mark here. Okay, for example, this one you should tell us this is a CT scan of the brain, axial plane, soft tissue or brain window, whether this is contrast or non-contrast. So this is non-contrast. So whenever you are given, for example, CT scan brain in soft tissue window, you always describe about the findings in the brain. You don't mention about the bones because you cannot see clearly. For example, if you are given bone window only, you describe the bones because if you look here, you cannot actually see anything in the brain. So same thing, if you are given CT thorax, lung window, soft tissue window, so certain things are actually not seen. So it's kind of weird if you start answering your exam papers telling abnormality here and there based on examination yang actually you cannot see the findings. So it must be a proper windowing. So as I told you before, hyperdense lesion in the brain, yang most common will be hemorrhage. Okay, hemorrhage. So you see this is subdural hemorrhage, this is extradural hemorrhage, this is intraparenchymal hemorrhage, this is subarachnoid hemorrhage. Okay, so another extradural hemorrhage, and if given bone window, then you describe the bone findings also. But sometimes the hyperdense lesion, you can also have calcification. For example, this one you see almost symmetrical calcification. Always think about physiological calcification first because it's quite rare to have katakan tumor belah sini sama sebiji sebelah sini. Okay, so it's quite rare to have unless it's a systemic punya illness. For example, your arthropathy, so semua tu, of course you can have bilateral joint involvement, but kalau tumor or anything yang ni, usually you don't have that symmetry. But if the calcification is too much, so macam ni is quite physiological or normal. But it can happen in certain, for example, hyperparathyroidism. Okay, so you can have excessive calcification. Or sometimes you can have calcification in a vascular punya lesion. Okay, Sturge-Weber that I show you on plain radiograph just now, gyriform calcification. So the calcification is along the gyri of the brain. Cysticercosis, I think this one is not common in our setting. Ni, if you go to conferences, for example, Thailand, where they like to eat raw fruits or itulah somtam lah apa semua tu kan, all these raw vegetables sometimes not properly washed, so you can have all this yang pelik-pelik, all this calcification ni lah, yang apa siput-siput punya telur tu. So if you go to conference to that side, it's not uncommon to see. Even bila buat x-ray pun nampak pelik-pelik calcification macam tatu kat dada. Okay, so all this telur-telur siput tu, so be careful when you eat raw veggie, ulam semua tu. Of course sehat in term of calorie and all lah, but not necessarily betul-betul sehat jugalah. Okay, so sometimes tumor can have wall calcification like that. Okay, so for mass lesion, because I think this one is quite common for you all, bagi exam question, intracranial hemorrhage semua jadi mass. Okay, so hyperdense lesion kalau mass, never as dense as a hemorrhage. Okay, you akan nampak sometimes compared to brain parenchyma is denser, and then ada calcification within. Or sometimes the mass dia sikit je dense compared dengan the rest of the brain parenchyma. And then even for this melanoma mets, okay, very subtle, you can see all this hyperdense foci. Okay, of course metal is so dense that it gives streak artifacts lah, like this. Okay, So we go next to hypodense changes or lesions. So if you see, if the hypodensity is involving both sides of the brain like this or very generalized, sometimes it's very, very difficult for you, okay, to diagnose. But if it involves like here, one side only, then it's easier because you can compare. Okay, so when you look at the density, you describe, okay, where is the density? How the density looks like, because here you see hypodensity but mainly within the white matter of the brain. You see the cortex or the gray matter, it is spared, and then you can see the finger-like projection. Compared to here, you see this is very well-defined wedge shape involving both white matter and also gray matter. So this one is usually caused by a massive infarction. This one, usually what we call as white matter edema. Sometimes there's a lesion sitting there which is not visualized until you give contrast. Okay, so mass effect. So for example, one patient came with one-sided body weakness. So initial CT scan. This one is initial CT scan. So you can see a faint hypodensity. Otherwise, what you can see that it's causing mass effect. You see unilateral ventricle shape is slightly different. So that's all that you can see. But actually there is already abnormality here, the hypodensity, which is very, very subtle. You may miss, but then you can locate using the mass effect punya sign. So this one, the CT scan repeat 1 day later, this patient actually having stroke. So this is early stroke. Early ischemic stroke. So 1 day later is better well visualized. So you see here the swollen part of the brain or the infarcted part. Okay, so it's actually multiple here, here and here. So mass effect, another thing that we see apart from asymmetry of the ventricle is the midline shift. Okay, so how to measure the midline shift? We draw a line between anterior forks and posterior forks. And then we measure to the midline punya area lah. So this is the midline. So we measure where is the how much is the midline shift. Usually the surgery intervention is required if the midline shift is more than 1 centimeter. Okay, so ventricles again. You see both have a dilated ventricles. So what's the difference between the two?
One is confined only within the ventricle, another one they spread in the parenchyma of the brain.
Okay. So what do you think is the diagnosis for this one?
Hydrocephalus.
What about this one? What about this one?
Brain degenerate.
Brain degenerate. So this is what we call cerebral atrophy. So this is hydrocephalus, the true hydrocephalus. So you see both shows dilatation of the frontal horn of the lateral ventricles. But if you see this one, the peripheral CSF space is also widened, so prominent. But for this one, it is compressing. Okay, so because this is hydrocephalus, the dilatation, so the brain parenchyma is actually compressed. So if you see here, this is a patient with hydrocephalus. So you see how much of the brain compressed because once they put the EVD in, so that's how the thickness, okay, the thickness of the brain parenchyma. So you see, this is how much compression. So that's why when there is acute hydrocephalus especially, it is important for us to diagnose and differentiate between the cerebral atrophy because neurosurgeon needs to insert the EVD. They have to drain the part of the CSF before more compression to the brain parenchyma, and it can cause brain damage. Okay, so they want to save the brain, they have to do it as emergency procedure. Okay. So contrast enhancement, we can see here non-contrast and contrast enhanced. Okay. So before giving contrast, you can see the hypodensity. As I told you before, this is white matter punya, because you can see finger-like projection like that. Okay. But once you give contrast, you can see there is a lesion inside, a ring enhancing lesion inside, and you see it's actually pneumocephalus there. So most probably it's abscess. Is either post-operation or as a complication, part of the complication of procedures lah, because dah ada pneumocephalus. You see midline shift there. So you see this is contrast because you see the vessel now is filled with contrast. Here no contrast, you could not see any vessels, okay, at the circle of Willis, at the base of the skull. So bone changes, if you're given bone window, then you can see the bone changes clearly, especially the fractures. You can see the fracture line, okay, the fracture line, and where is the displacement of the fragments, okay. But usually it's important also to have a plane to look for the soft tissue or brain window, to look for any intracranial hemorrhage, okay. So now we test again. It's already 10. Yes, please. Is it contrast or non-contrast?
None.
Why you say non-contrast?
We cannot see any blood vessels.
Yeah, so if you give contrast, I expect to see the blood vessel here, the basilar artery here, the posterior cerebral artery here, the middle cerebral artery here. At least I can see part of the vessel. Okay, go on. So, description of findings is, you have to describe first before you give diagnosis. Okay, so I mentioned before, if no bone setting or bone window given, do not mention about bone findings. Yes, you can see hyperdensity, but you see there is hyperdensity in the left basal ganglia, okay, or the left lentiform nucleus. Okay, that's why again your anatomy is very, very important. So now you know the difficulty. If you do not know your anatomy, is when to describe the findings. when you want to name the location. Okay, so that's why at least for brain, this part, this slice, you really have to know what is this region, where is the internal capsule. Okay, at least this slice you really have to know lah, because most of the time the pathology or the images given in exam will be at about this location. Okay, so you see the hyperdensity in the left lentiform nucleus, or you can say basal ganglia region. Okay, so it is you can say it's homogeneous, although slight heterogeneity at the lateral part. You can see minimal hypodensity surrounding it. Okay, minimal hypodensity surrounding it. Okay, so minimal edema surrounding this one, this hyperdensity, and you see there is a bit of mass effect. You see compression of the frontal horn of the lateral ventricle. This one is this size, so you see this one is smaller because compressed by this lesion here. So this one is also looks compressed even though there is no midline shift. Okay, and then rest of the brain looks normal. You see another symmetrical hyperdensity at both basal ganglia here. Okay, so this one is actually acute intraparenchymal hemorrhage, and this is the normal physiological classification of the basal ganglia. So this is acute intraparenchymal hemorrhage. So most common cause is hypertension, but it can also due to drugs. So you have to get the history on any drug, and then thrombocytopenia, patient with dengue fever, or sometimes ruptured aneurysm can also cause intraparenchymal hemorrhage. Next. Nobody want to try this one? Okay, I think we are going to waste time here, but you are all already year 4, so practically we are training you to be junior doctors now, so you really have to develop your confidence in presenting, and you can see if it's only me talking, you can actually you cannot practice. So I can give lecture for 1 or 2 hours, but whether you can apply the knowledge or not is very, very difficult to tell. So unless you talk, unless you present something, then I know what is lacking, so that something that I need to explain more, something I need to focus on. Okay, so you really have to develop confidence in start to present. So because this is what you are going to do once you're houseman, it is going to be your daily work every day. You have to present all the histories, the blood investigation results, the radiological findings. So especially you already have gone through your medical posting, surgical posting. So 2 weeks, if you ask me, is not enough to learn radiology. Okay, so that's why only 2 weeks allocated, because it is assumed that you already have exposures to all this imaging. So coming to our department, we are going to just polish your knowledge. Okay, so again, if you do not talk, it's difficult for me to concentrate where is the where you do not understand or something like that. Or okay, so it's better to make a mistake while you are learning during student years, rather than making mistake when you are already being put responsible for the patients. Okay, so that's why nowadays whenever you go to any class, never hesitate, never be afraid to make mistake. Do not really think what your friends will say. If I say something then it's wrong, then everybody will laugh at me. Never think about that, because next for us, we are going to treat patients. So once you graduate, you have to, the housemanship 2 years is very, very short. Okay, then you'll start to have responsibility to treat your own patients. So we do not, if possible, like I said, make mistakes now rather than later when you are going to be held 100% responsible for your patient, for example. Okay, so now you make mistakes, somebody is there to correct you, to guide you. Okay, so so I expect something like that. Okay, so I think time is almost up. So what I'm going to do is I'm going to conclude the session. So for MRI, it's almost same with CT scan. So whatever changes, the only thing is the I think the terminology we use slightly different. So abnormality, which is bright, we'll call it hyperintense. Which is black, we call it hypointense rather than hypodense and hypodense. So remember that when you answer your exam questions. Ultrasound is hypoechoic if it's dark, hyperechoic if it's bright. Okay, so make sure you use a correct term. Okay, again, identify the examination, hypo or hyper intensity, the mass effect, hydrocephalus, the enhancement. Okay, so structural abnormality, there are many structural abnormalities that we can do to assess abnormal brain. Okay, but this one is usually not exam related, so it's nice to know, but it will never come up for your exams. Okay, so I'll skip the vascular imaging. You read on your own. Okay, so as a summary, most modalities has its advantages and disadvantages. So in clinical setting, sometimes there is more than one modality used for a single entity disease or a single patient. So that's why we really have to learn everything. Okay, so that means if you do radiograph or x-rays normal, you don't stop there. So maybe you need to go further. So do further whether CT or MR, which one is better, which is at more advantage or disadvantage, then that's what you have to learn. Okay, so if you want to practice on how to write findings, you can try this. I've prepared this for kuliah allied health students, but it can be used for you also. I think a few cases here, KHS CNS 2020, I think only one spine, the rest are all brain. So answers already given there. Okay, so that's all. Thank you. Any question?
Thank you.
Any question?
At the moment, no. Yeah.
Okay, so if there is no more question, I'll end our session today with Tasbih Kifarah and Surah Wal-As.